Good afternoon. So thanks very much for inviting me, Juan, Stacey. Just a confession to start. I've failed on the green. I knew I should have done something, but I failed on the green. But the other thing I've done, I've promised not to make any comments about unusual politicians. So that takes out half my talk. David, my colleague, has kindly shown you how the mechanics of the thing works, how the plumbing and how the light works. So I won't have to do any of that. I'll just concentrate on demolishing his argument, which I will start if he passes the pointer. Is this the pointer? It works. Oh. Okay. So this is why we thought that PDT was a good idea. So on the left you have a lump. Here we go. On the left you have a mass in the liver. It's an intrahepatic tumor. And on this side, you can see where it gets infected, and you can see the abscess cavities developing in it. And before we had excellent plumbers like David. He admits that most of his job is in fact plumbing. Before we had excellent plumbers like him, people with cholangiocarcinoma used to die of this. They used to die of infection because you simply couldn't get rid of this. It was just impossible to get rid of. And that, of course, has been improved hugely by people like him, because you place a stent. So here's he's shown you something very similar to this. Here's the bile duct here, and you place a guide wire up here, and you place this mesh, this iron mesh, which slowly expands over the course of a few days and improves the drainage. And people feel very much better for this, and it's, I think, saved many thousands of lives. But what comes, and we think that it saves a lot of lives because this leads to less infection, and people don't succumb to the dreadful infection that they used to do. These data come from Juan and I. We did a big study a while back. And the important figure really is any type of infection down here, and you get less infection if you have better treatment, and certainly that's administered by a stent. The difference, of course, here is that this is not stent-related treatment. This is chemotherapy-related treatment. So the idea was that any way you can improve your drainage, any way you can get rid of any chance of infection, you do a bit better. This is chemotherapy, and certainly it did it there. Stents certainly do it, but could anything else do it? And it all came down to, well, part of the explanation comes down to this guy, your standard eponymous French late 18th century physician. You see something and you describe it, and it's all about flow. And the bottom line is if you have a tube, you increase the size of that tube by a factor of 1, and in fact you increase the flow through that tube by a factor of 1 to the 4. It goes up to the power of 4. It's a huge improvement in the drainage simply by increasing the size of that tube a very little. And this was, in fact, the principle behind the original PDT studies, to improve flow. If you improve flow, you decreased your infection, and you did better. And so far, so good. And this is Marianne Ortner's study, which David's already mentioned, and it was really very dramatic result. About which we scratched our chins for a very long time. It was a bit unusual in that all the patients in the study were jaundiced, and that's not normally not necessarily the case for all patients, all cholangiocarcinoma patients coming up for treatment. And but not all the patients had chemotherapy. Actually, when it was done, chemotherapy was not necessarily a standard treatment for cholangiocarcinoma. This is 13, 14 years ago now, remember. But most critically of all, the numbers are tiny. 39 patients randomized. So that in fact it was 19 patients in the PDT arm. And we were under some considerable pressure, I remember at the time, to completely change the way we treated cholangiocarcinoma patients because of these 19 patients. So after resisting this pressure for a little while, we decided to answer the question properly, and I'll just tell you how we did that, and that will probably finish them off. So the way we started was to do PDT. So PDT wasn't really done in the UK at that time. So we ran it through I think three centres to just get a feel for how to do it, and that went pretty well. 35 people had PDT, nothing really in the way of side effects, and that actually went quite well. So what do we do next? We expanded it. We do what you have to do to prove something works. We did a randomized study, and this was called Photostent 2, and the first one being Photostent 1. And the question was very straightforward: does PDT enable you to live longer? Because after all, that's what we do. That's the whole idea. And the rules, the eligibility criteria, the rules for getting into the study are pretty standard. And apart from this thing down here, so performance status. Whoops, how do I go back? Here we go. Performance status 3. That's a little unusual for studies. So that means you're really quite poorly. That means you're not terribly well. And the idea was actually that you could have this despite being not terribly well and get away with it and still be quite well afterwards. So that was the only thing that really stood out here. Otherwise, it was pretty standard, well balanced, well thought out study. So that went ahead. The intention was to look at 240 patients. So some people just got PDT, the other patients just got the stent alone. So the idea is that stenting is pretty good, and the question was whether PDT added to it. And you had to compare these two groups, and you compared the quality of life of the people on the study as well. So that's the standard way us trialists do these things, because we're trained to do it that way. And the endpoint was survival. So whether it made people live longer, that's after all the most important thing. And the trial was closed to recruitment early. So that's the second time we've heard that today. Whether this was for the right reason or the other one was for the right reason, I'll leave you to judge. But it was closed to recruitment early when we hit 92 patients. And I'll show you why in just a second. The patients were pretty standard. Again, nothing unusual about them. Not probably representative of those patients we have in this room, but a very representative selection of patients. So nothing wrong with that. You couldn't fail that. The way in which the treatment, the PDT, was delivered. Yes, I mean, once again, nothing wrong with that. You couldn't fault the way in which the PDT was delivered. Interestingly, the time from, so if you had PDT, so this far column here, the time to getting your next stent. So people have to have stents maybe once, twice, sometimes 3 or 4 times, but the time to your next stent was a bit longer. So maybe the PDT was doing something. Maybe it was improving the drainage as we hoped that it would do. But this was the shock, and this was why they made us stop it early, and we didn't expect this. This is why we do these things in a blind way. We didn't know the outcome, and the data monitoring committee, who are faceless guys in a room somewhere, tell us to stop because they look at these things and they see that the people who have the PDT, so the people who have the PDT, so that's a solid line, do less well than the people who didn't have the PDT, and so there was a potential there that we were actually harming people by doing the PDT. So we stopped. There's one thing to note out of this, and that is that the damage happens pretty early on. So there's something, once you get down here, it's pretty balanced, and so something happens pretty early that makes this treatment fail. What was it? Well, we spent some time trying to hunt it out. So this is the progression. So this is the progression free. So this is the graph of when people develop more cancer. and that's about the same. So it's the suspicion then comes down to it's something that we're doing to the patient rather than the cancer itself. So we move on, and one of the reasons was the fact that some of these people didn't in fact go on to have chemotherapy. So if you went into the study and you drew the PDT arm and you had your PDT, you felt pretty good about this. You'd had something, you wanted to just see how it went. Did you want to have chemotherapy immediately? Not really. I've been through this procedure. They think it possibly works well. I'm going to see how it goes. And that was an extremely reasonable thing to do. If you didn't get the PDT, you were on the phone immediately saying, give me some treatment, do something for me. And so more people who didn't have the PDT went on to chemotherapy, and they did so. The other thing we found out was that they did so much sooner. So most people who didn't have the PDT were on chemotherapy within about 4 or 5 weeks. Those who had PDT, if they had chemotherapy, it was like months before they got onto it. So that was the other thing. But then the most worrying thing really was why did people do worse early on? And we looked at this, and the bottom line is if there was a small group of people, I think about 9 or 10 people, who developed bad liver function. So we know what that is. Those are our liver blood tests and the bilirubin and what have you. And they developed bad liver function after the PDT, and more of them did so after the PDT than if you just got stented. So the PDT was bothering the liver a bit. And okay, that's not such a big deal. We do terrible things to our livers the whole time. But in fact, if you did have worse liver function, you really did much less well. So your survival, if you had bad liver function after PDT, was dreadful. That was really bad. Whereas if you had bad liver function after your stenting alone, you did less well. So there was something, and that explains the early drop-off in survival, and that we think is probably the most critical factor here. So that's why I don't think people should have PDT. So to summarize that, and I hope that hasn't been too difficult to follow, to summarize that, I would not give PDT in cholangiocarcinoma at the moment because of our experience with it, and because we know it can upset the system in such a way. Should you never have PDT? Well, probably not. I mean, if you need to be very, very careful is the bottom line. If you need to be very careful about your liver function. You need to be careful about looking after the patient. You need to be really observant about these things. So I'm never going to say that PDT can never help, because that's completely untrue. But you need to be extremely careful about the situation in which you use it. We know why in our study PDT didn't work, and how the liver function contributed to a worse outcome. It's not to say that another novel type of PDT agent, some super special new stuff that comes along using the PDT technology, it's not to say that something like that will not turn things around, will not deliver better drainage, will not improve survival. But right now, I don't see anything that's going to do that. So thank you everybody for listening. Certainly the patients and carers who went through this, the funders and the trials unit, and thank you very much for listening.